Thanks, Sue. And can I invite the other speakers from this morning to come up and join us on the panel? I have a handful of questions, and I think some of the parents from the parent organization are going to come around to get some more questions. But this way we can kick things off for the next half hour or so before lunch. And by the way, lunch is going to be in this room as well. So you guys can share this one. I'll use this one. Okay. So our first question is for Dr. Swedo. From a comment that you made during the first talk, why is a false negative throat culture the most dangerous thing you can do to a child in this context? As a pediatrician, false negative throat cultures are very common.
So the reason it's such a dangerous thing in this trial, as is a single titer that's sort of equivocal, is because then people say, oh, there's no strep, I don't need to treat that, or no strep, we don't have to think about this as pandas. And that's actually where I'm going. The most common, yes, it is very common for throat cultures to be negative, and we really advocate an adequate swab. So if Dr. Murphy was up here, she'd tell you have to get back there and make the back of the throat bleed. I was actually not taught to be that aggressive, but you do have to get up into that upper pharynx, almost at the junction with the nasopharynx, and you have to swab enough that you make sure you get bacteria on your swab.
This is a terse question, and I think it could be for both Dr. Swedo and Dr. Day. If one of these diagnoses is not diagnosed early, can permanent brain injury occur?
I think the unfortunate answer is yes, in the case of pandas and Sydenham's chorea. I'm going to turn that question around and then ask Dr. Day to do both. He showed you data suggesting that even if it is treated early, there might be permanent damage, and I'm afraid we don't know what distinguishes that. So we've had plenty of patients who were not treated, right, before we knew what this was and how it was going, who actually had bad OCD and pandas picture in early childhood, and then they spontaneously remitted and never had any problems again. We also had those young men who had chronic treatment refractory symptomatology, and our Sydenham chorea patients, we've just finished 10-year follow-up on them, and just as you heard from the AE, they actually have evidence of cognitive behavioral deficits that continue.
So I think what I'd add to that is if you don't look for impairment, then patients are all doing well. So the romantic era can continue, but the more that we do look for impairment, the more we learn that it is a disease-specific course and disease-specific long-term outcomes. So some of the antibodies, especially the ones that target neuronal components, do lead to T-cell responses and cytokine responses and neuronal destruction. And in those diseases in particular, the impetus becomes the need to treat early is to prevent neuronal loss. And we do see in those patients longer term, there's new studies coming out showing atrophy in subsequent brain MRIs. With diseases like anti-NMDA receptor encephalitis targeting receptors in the synapse, in a Petri dish, it looks pretty good. You have an antibody there on the receptor, you remove the antibody, the receptor comes back out. But when we follow these patients long term, the cognitive and behavioral disturbances are still detectable even as far as 2 to 3 years out. So I think that's part of the impetus for diagnosing and treating earlier, is that we are having emerging evidence to suggest that neurons can be harmed in the making of these diseases.
I can add one comment, not about the paraneoplastic disorders, but about Sydenham chorea and disorders like that. It's very clear there is evidence there are long-term, generally mild, but long-term behavioral abnormalities, meaning they're different from people who didn't have Sydenham chorea. But what we don't know, not everybody who gets a strep infection and not everybody who gets rheumatic fever develops Sydenham chorea. What we don't know is what their function was like before this happened, and is there something that makes people particularly susceptible to developing Sydenham chorea that reflects their baseline function of their brain prior to developing that. And so that's a very hard question to answer, but it it is something that is a possibility as well.
Okay, more questions coming. So I am, cards are physicians, yeah. So the pieces of paper that came up that aren't cards are from parents, I gather, and the intent is to have those questions addressed tomorrow. I'll say some of the questions that I've seen already from the parents, the talks later this afternoon will address those. So Dr. Sylvester, some interest in anxiety. When is a treatment for a young child, say less than 10 years old, with social phobia, or I'll say any other anxiety disorder needed? How bad should the symptoms be? And sort of a secondary question: is it true that is it a true phobia if you can bribe the child out of it?
Well, I mean, it's always difficult to exactly draw the line between what is a typical fear and a disorder. I mean, we certainly see some extreme examples where it's obvious that a child is severely impaired. But the simple answer is when it starts to interfere with the child's life, with their quality of life. So if they're not making friends, or they're not engaging in activities that you know that they want to engage in. For example, you know your child really enjoys soccer but just won't go because they're worried about how they're going to look in front of the other kids. So once it starts to impair in their life, is usually, and the other answer to that question is there are always ways of helping a child, even if they only have subsyndromal symptoms of an anxiety disorder. So some of the therapeutic interventions can be helpful for a child, even if they don't meet full-blown criteria. So it's always, I think, useful to use some of these techniques, even if you don't, definitely draw the line there. And then the second question was, well,
if you can bribe a child out of it, is it a true phobia or a true anxiety disorder?
Yes, it can be. There's always an interaction between motivation and fear, and one of the tricks that we use in cognitive behavioral therapy is motivation. So I had one particular patient that I myself took through cognitive behavioral therapy for separation anxiety. And it was very difficult to get her to separate from her mother, to let her mother, we worked up towards having her mom drive away from the clinic. And then we hit upon the idea of she was going to make a video on a cell phone telling other kids how to overcome their anxiety. And she was so excited about making this video that almost immediately she was like, yeah, Mom, go. And then she was very excited to then make this video that she could show everybody else. And so we motivated her, but she was still impaired by the anxiety in other situations. So there's always an interaction there.
The next question, I'm going to sort of build off of the way it was phrased and just ask Drs. Cunningham and Day to address: how do you use information that comes off of an antibody panel, whether it's from Mayo or Moleculera or some other source, to use that to understand severity, treatment response, prognosis? What information can you actually glean about dimensionality of the condition from information from one of those panels?
So that's an excellent question. Again, it tends to be specific, at least the evidence that we have tends to be specific to some of the syndromes. I think the first question to ask and answer yourself is, does that antibody make sense in the clinical picture? So one of the great dangers of having these big panels is that you expect the patient to have one disease and it comes back with another antibody associated with something else. And it may not be false positives, it may simply be that some antibodies group together, as we've talked about before, and that may trigger or steer you towards other investigations. But in terms of grading the severity of the illness, at least in terms of many of the anti-synaptic or anti-receptor antibodies, it doesn't necessarily predict illness severity. There are exceptions to that, and if you're going to make any reliance on anything, you have to have the same sample processed at the same site in the same way, and it should be from the cerebrospinal fluid. So there's no real correlation in serum antibodies, at least in diseases like NMDA receptor encephalitis, with severity. Where it does become a very good marker, though, is in the future. If you establish that your patient who's now improved has a baseline level of antibodies, which may persist for many years, and is asymptomatic, and they come back with maybe subtle psychiatric symptoms 2 years later, we need to clarify, is that anxiety, is this depression, or is it related to their disease? And in that case, seeing an elevated or increase relative to their prior baseline can be useful. But it really is a case-by-case basis. There's certainly no published standards that I'm familiar with.
Of course, I'm asked that question a lot, and I've thought about it. One thing is that when you see autoantibodies in serum or CSF, it tends to lead you to believe, based on the symptoms, that the person may have a disease that is related to autoantibodies, and then that potentially may have an impact on treatment. You might be testing something like a steroid to see if it works first before you go to any more of the therapies like IVIG or a plasma exchange, but certainly the presence of the autoantibodies alone gives you the ammunition to say that it is an inflammatory disease, because the antibody can either be a biomarker of inflammation that's actually going on in the patient, or they can be a sign of potentially the cause, what might be the cause of the disease. And then, of course, the other questions are about what does it really mean, and I've been thinking about that, and I think we're going to gather all of our data together and write an article on the sensitivity and specificity of the antibodies that we've studied in pandas. I know that Dr. Sweeto has studied, for example, ANAs that are in these patients, and really only about 50% of the patients will be positive, whereas with the panel of antibodies, really almost everyone that has these symptoms, most will come back. I mean, it may be 95%, but it's really very accurate. Whereas if you use the ASO, anti-streptolysin O, or anti-DNase B, 35 to 40% of the children basically you're not going to see it. So you will miss it again if you're trying to use the infection to tell you, because it may not be the answer that you're looking for. So the antibodies can be very definitive, and I think, as Dr. Day put it, especially in the clinical picture.
Several questions converge around using IVIG. So I'm going to try to merge them together. So a big issue would be when would you, in the course of caring for a patient you've diagnosed with PANS or PANDAS, and you're thinking about implementing IVIG, maybe you're the third or fourth physician to see the patient, and the symptoms have been present for months, 1 month, 3 months, 6 months, and so on, years perhaps. Under what circumstances would you say it's been too long standing and I don't expect to see a response from my therapy? What's the window of efficacy for IVIG?
So I don't think we know the answer to that question from sort of prospectively collected empiric data. I can tell you that we looked at duration of illness in our first trial and did not find any association between degree of response and duration of illness, and some of those children had been sick for as long as 18 months. Not very many. Most had been sick on average about 6 to 7 months by the time they got to us. So definitely if it's in the first year of symptomatology, there may be a treatment response. I don't think, unless the child is just needs to be in the hospital for care, that ill, that you have to rush to this. I would definitely try antibiotics first, and if that hasn't helped within 3 to 4 weeks, then you might think about steroids or IVIG if the child is not getting to school and has significant impairments. Beth Latimer in the Journal of Child and Adolescent Psychopharmacology, JCAP, published a consecutive case series of 35 children treated with plasmapheresis at Georgetown. Among those 35 children, there's actually a graph in there looking at timing of plasmapheresis versus degree of improvement. Some of those children had been sick as long as 3, 4, 5 years before they went through plasmapheresis, and again, no association. So I don't think it's too late in sort of the semi-acute phase of illness. I would say that I wouldn't be trying this on young adults who have had symptoms for a very long time. although one of our colleagues in private practice also says he's going to write up that case series. But for me, they need to still be children and adolescents, and I prefer to see some evidence of ongoing autoimmunity.
The only comment is looking at the data you presented from your recent trial, where looking out very clearly there is an acute phase, or when they present, and then over time they all improved. And for every disease we know there are outliers, but what that suggests to me is that, you know, that's kind of the typical what you might expect is, and that's what we see with Sydenham chorea. It's acute onset. There are some that may have persistence of symptoms for a year, but the symptoms tend to improve. Where I sit, which is as a neurologist who firmly straddles the border between psychiatry and neurology, I get a lot of patients referred to me who have had tics, OCD, anxiety for 3 or 4 years, where the question is this PANDAS? And second of all, can you continue giving my child IVIG because the previous doctor I saw won't? And I think that, again, we don't know how many of these are true outliers and what you've been talking about versus something that is an entirely different disorder.
And a related question from probably the people on the front lines, how do you get coverage for IVIG or pheresis? Have the insurance companies started to pay for this indication? The people at the NIMH may not have as many stresses and strains.
We do
about
not
this.
have to actually pay for it. But I do spend an inordinate amount of time talking to clinicians and trying to get coverage. And because I am in the ivory tower, I don't know what the code is, but you guys probably do. That's why we work so hard to make a diagnosis of an autoimmune encephalitis, because the AE not otherwise specified is reimbursable for all of these various things, including the diagnostic evaluation. So that would be my answer.
The suggestion here was move to Canada, but I can affirm. But again, they only pay for it in select diagnoses, and the governments are increasingly, due to the cost of IVIG and the potential risks of IVIG, require supportive evidence. So I think that goes back to the value of the history in establishing that history, and of being convinced yourself enough to advocate and write those letters and be on the phone with the right people. And then the value of diagnostic tests and objective measures really can't be overstated in this disease. So the case from 1999 of the woman with an ovarian teratoma, that team had to fight to get her IVIG because it's not been described. But now we know that IVIG is one of the first-line treatments in NMDA receptor encephalitis. So
I think most of the insurance companies turn to the Archives of Neurology article that says that IVIG is not contraindicated, but there is no indication for it in PANDAS or even in Sydenham chorea. If you run into that situation, you can actually turn to the circulation in the American Academy of Therapeutic Apheresis, which gives plasmapheresis as a second-line indication for Sydenham chorea and a first-line for PANDAS. So there's some, that's how we do it, is we just point out the conflicting data in the literature and then show how this patient is unique.
Some other questions about treatment, and is John Manavani still out there, John? Did you ask me this one? Has anyone had experience with effects of CBD oil? No, that wasn't you? Okay. All right. So this is a question that's active right now because, well, Missouri has made it possible for patients with intractable epilepsy to have cannabidiol, a non-psychoactive version of marijuana. Does anybody have experience with this therapy for PANDAS or anti-NMDA encephalitis? I should also point out that Illinois is a medical marijuana state now, and Tourette syndrome is on the list of indications. Any experience with the CBD oil or no? Haven't heard about it. Good, good. All right, I'll skip over that one then. All right. One of the ideas out there for treatment indications or contraindications has to do with SSRIs. There are some who are worried that SSRIs exacerbate psychiatric symptoms in patients with pandas, but we also heard today recommendations to use them for their treatment. So one of the questions for Dr. Sweeto, if a child with anxiety OCD is tried on an SSRI and has a very negative response, as is often seen in private practice, would that be an indication for an autoimmune encephalitis PANS workup? And then as a follow-up, basically asking whether there's strong evidence for the use of SSRIs in that setting.
So I'm going to turf this question to my colleague Margot Tienemann to help handle this afternoon, but I will share my experience has been that the children who get in trouble with an SSRI, it's when it's given very early in the course of illness and the dose is ratcheted up. These kids are so sick, you sort of want to do everything you can for them, but if you give them an SSRI, any person who goes onto an SSRI may have some activation, and the activation actually feels to them the same as that anxiety, and it does cause them to be more uncomfortable, maybe more out of control. My dear friend and colleague Henrietta Leonard taught me that you start really low and go really slow, and you can use SSRIs. You might not want to use one of the more activating ones, but you can use some of the less activating SSRIs, and they can be incredibly, incredibly useful. They treat not only the obsessive compulsive symptoms, but also the anxiety, the comorbid depression, and the other psychiatric symptoms.
And I was just going to say that the SSRI we used in our animal model after immunization with strep, it did work to alter the symptoms. So it could work. I mean, yes, I guess there are some problems, but.
There's a question are we overlooking other potential pathogenic mechanisms such as, for pandas, such as mitochondrial disorders, fatty acid oxidation disorders, other kinds of ways in besides the mechanisms that have been focused upon today?
Yes. No, they're in that differential. They're in both the JCAP article and also in the CANS article that was in Pediatrics as part of the differential diagnosis. Again, it would be unusual for mitochondrial diseases, for fatty acid disorders, for, let's say, Lyme disease, to have an abrupt overnight onset of the symptoms. They tend to have been sort of cumulative, a more semi-acute onset of illness. So acuity of onset, to me, points you down a very different differential.
The other thing is to have those symptoms in isolation. So just OCD or the triad of OCD and behavioral regression. And to have these symptoms in isolation would be extremely unusual for inherited metabolic disorders and mitochondrial disorders. We may see, there's a long list of things that can cause tics. You can see tics in Huntington disease, but you never see tics as the only symptom in someone with Huntington disease. So I think that's the most important thing is, yes, you can get these symptoms as part of many, many different disorders, but in isolation is not the case.
We do a lot of strep cultures, but we also are aware that there's a lot of carriage. Is that the bad one? Okay. There's a lot of strep carriage out there, and it can be difficult to discern when we get, if we're always checking a throat culture when a patient is symptomatic, how do we discern practically carriage versus true infection?
So a strep carrier is defined as an individual who has a positive throat culture because there's the presence of strep bacteria in the oropharynx without an immune response. There's no antibody titer rise in response to that strep. And true strep carriers occur in less than 5% of the population. Asymptomatic strep infections are determined more frequently in up to 15% of the population. In both of those instances, basically the diagnostic test ends up being treatment of the positive throat culture and then another culture at the end of treatment. So let's say a child comes in, you think it might be pandas, you culture their throat, it's positive, you have an obligation to treat that positive, but then you reculture 3 days after the end of antibiotic treatment. If it is still positive, that's a good clue that that child might be a carrier because the strep is just lingering about in the throat. And clearance of the carrier state in that child may be warranted, might not, but it would actually suggest that maybe that strep was just a red herring and had absolutely nothing to do with their behavioral symptoms.
This is a question, I think, for Drs. Cunningham and Day. Anti-dopamine receptor antibodies have been noted in other autoimmune encephalitides, such as and basal ganglion encephalitis and others. Can you comment on the specificity of the DR1 and DR2 antibodies for Sydenham's chorea and PANDAS outside of these other autoimmune encephalitides?
Oh, well, I have not studied the specificity of the other anti-basal ganglia encephalitides, but we do have peptide epitopes that we have studied. I can't just rattle off the sequence of the epitopes, but both for D1 and D2, the antibodies do recognize specific peptides. I don't know what more, I could say really in regard to comparison of those diseases. Maybe Dr. Day can.
Well, I'll hedge quite a bit on that because it's not my specific area of clinical practice. But one of the papers that the person who asked the question may be referring to is published in Brain a few years ago, looking at D2 receptor antibodies and describing that universally in their cohort of patients with basal ganglia encephalitis, in a relatively high frequency. I think a third of people that they looked at with Sydenham's chorea, and then a few people even with Tourette's syndrome. But I think if we back that up, the better question becomes, what were the clinical picture in each of these, and are there better clinical ways to stratify those people? So we can use the antibodies there to improve our clinical characterization by considering that small, I think it was 10% of people that had a label of Tourette's syndrome. Did they really have Tourette's syndrome? Was this something else? Should they have had an alternate diagnosis? That was specific to the D2 antibodies, and that's about as much as I can comment on, other than to say that these are the studies that we need forthcoming. We need well clinically characterized populations that receive thorough testing of both D1 and D2 antibody status so that we can begin to answer those questions, both about sensitivity in certain populations, but more importantly about specificity if we're going to use them to steer our diagnostic labeling and treatment decisions.
So I'll for this last question before we have lunch, I'll just use the moderator privilege because I don't know that John's going to be here tomorrow. So there's a question from one of the parents that there was discussion about tics in young children, and the question, and we didn't really talk about treatment, so is there any treatment for tics in children other than psychotherapy or cognitive behavioral therapy?
Yes.
Would you care to elaborate? Yeah.
So treatment of tics in young children depends on what you mean by young, but treatment of tics in young children, we're in an era where there's a change in clinical practice. There are many medications that can be effective for reducing tics, and they include things like alpha-2 agonist, guanfacine, clonidine. They include topiramate, Topamax has been shown in one study to be effective. Dopamine receptor blockers can be effective. Behavioral therapy, so-called comprehensive behavioral intervention for tics or habit reversal therapy is as effective as some of our best medicines. And increasingly, people are going to that as first-line therapy. So behavioral therapy, pharmacologic therapy, sometimes a combination, sometimes benign neglect. The tics are present and they're not causing a problem. Our first-line treatment is actually education and reassurance. So there are lots of things. The last point is in a child who has anxiety and tics, we don't have any data on this, but I think most of us who see a lot of kids with Tourette's syndrome, if they have substantial anxiety, if you treat the anxiety primarily, their tics either improve or they don't bother them nearly as much.
Thanks. So with that, I'd like to close the morning session. If I didn't get to your question, I apologize. I hope you've enjoyed and have been edified by the morning, and come back at 1 o'clock for the rest of this engaging program. Thanks.